Hello, this is Ahmed Khattab and today I'm going to talk about hyperkalemia. But before we talk about the causes and the management of hyperkalemia, we need to understand the regulation of potassium homeostasis. Ready? Here we go. This is a cell. Well, not really, it's just a square, but for educational purposes, let's pretend it's a cell. As you can see, 98% of the potassium is inside the cell and only 2% is extracellular. The extracellular potassium is what we measure in the lab, and it ranges between 3.5 to 5 milliequivalents per liter, and it's strictly regulated to be kept in that tight range. Two questions must be answered right now. First, how is it regulated to be kept in such tight range? The second question is, why is it kept in such a tight range in the first place? Okay, let's go ahead and answer the first question, which is, how is the potassium regulated? We typically get around 100 milliequivalents of potassium per day in diet. Of that, around 10% is eliminated with feces. That leaves us with 90 milliequivalent that will go to the extracellular fluid. So how would the body react to keep the potassium within the normal range? Well, a normal kidney is very efficient and able to handle all the potassium that comes in and excretes it in the urine, and is responsible for maintaining total body potassium by matching intake with excretion. Well, that sounds good, but the problem is it takes several hours for the kidney to get rid of all that potassium. The body needs a quicker response than that. So what happens initially that the extracellular potassium is buffered by movement into the cells, and specifically the skeletal muscle cells. This is known as the internal balance of potassium. Okay, now let's have another look at the very same square, but we're gonna make it a little bit more sophisticated as a decent cell should look like. We're going to add some receptors and pumps. This is the sodium potassium pump, and this is the insulin receptor, and this is the beta 2 receptor. Almost all cells have sodium potassium pump. Its basic function is to let the potassium in and kick the sodium out, utilizing ATP as a source of energy. What happens after a meal, there is increase in glucose and potassium, and that stimulates the pancreas to release insulin. Insulin binds to its receptors on the cell surface, which stimulates glucose uptake in the insulin-responsive tissue through the insertion of glucose transporter protein 4. This increases the activity of the sodium-potassium ATPase pump, mediating potassium uptake. Catecholamines act on the beta 2 receptors, inducing sodium-potassium ATPase pump to uptake potassium. This effect plays a role regulating potassium during exercise. What about other factors that influence the internal potassium balance? Well, two factors should be mentioned: tonicity and acid-base disorder. Let's have an example of tonicity and osmosis, so it's easier to understand how that can cause hyperkalemia. This, as you can see over here, is a bucket full of water, and this is a semi-permeable membrane. Now I'm going to add 10 spoons of sugar on the right side of the membrane and only 1 spoon of sugar on the left side. You can clearly see that the sugar concentration is higher on the right side. So what happens next is water moves from the left side to the right side, trying to balance solute concentration. Water movement across the semi-permeable membrane is known as osmosis, and the relative solute concentration across the membrane is known as tonicity. So as demonstrated, water moves from lower tonicity to higher tonicity, trying to balance the solute concentration. Now let's apply that on a cell. If there is hyperglycemia, that means more glucose in the extracellular fluid than inside the cell, and that equals higher tonicity, which makes inside the cell lower tonicity. What happens now? Exactly the same as happened before. Water moves from lower tonicity to higher tonicity. Water diffusion to the extracellular fluid will drag along potassium, creating hyperkalemia. Furthermore, as water moves out, the cell shrinks, creates more favorable concentration gradient for potassium efflux. Now, let's talk about metabolic acidosis. It has always been thought that the reason behind hyperkalemia and metabolic acidosis is simple, direct potassium-hydrogen exchange. But this is not accurate. To understand how metabolic acidosis leads to hyperkalemia, have a look at this. This is the sodium-potassium pump. This is the sodium-hydrogen exchanger. And last but not least, the sodium bicarbonate co-transporter. The sodium-hydrogen exchanger, as the name says, exchanges the intracellular hydrogen for the extracellular sodium, and the sodium bicarb co-transporter co-transports extracellular sodium and bicarb at the same time to the intracellular space. And as we know by now, sodium-potassium pumps the sodium from inside the cell to outside the cell, and potassium from outside to inside. So what if the intracellular sodium drops? The pump would not be able to function, and thus will not be able to get the potassium in, leaving it outside in the extracellular space, causing hyperkalemia. How does that happen? Metabolic acidosis simply means there is more hydrogen and less bicarb in the bloodstream. More hydrogen means that the sodium-hydrogen exchanger will not be able to work, resulting in lower intracellular sodium level. And less bicarb will mean that the co-transporter will not be able to work, leading again to the very same result, which is lower intracellular sodium. And why is that a problem? We just said it will stop the sodium-potassium pump from working, leaving the potassium outside the cell, causing hyperkalemia. And that's how metabolic acidosis leads to hyperkalemia. Now we're done with the internal potassium regulation. We are going to talk about renal potassium handling. Before we go ahead, we have to mention a few facts. Fact number 1. Potassium is not bound to plasma protein, so it is freely filtered. Fact number 2. 90% of the filtered potassium is reabsorbed in the proximal tubules and loop of Henle. Fact number 3. Only the distal tubule and the collecting ducts are capable of both reabsorbing and secreting potassium. Fact number 4. 3 major factors are required for adequate potassium secretion. A. Adequate aldosterone secretion. B. Adequate responsiveness to the aldosterone secreted. C. Adequate water and sodium delivery. Okay, so how is the potassium secreted? Let's have a look at the principal cells and the distal tubule and the collecting duct, which is the key segment responsible for potassium secretion. This is the basolateral membrane facing the blood, and this is the apical membrane facing the tubular fluid. Reabsorption is movement back to the bloodstream where it was originally, hence reabsorbed. Secretion is moving towards the tubular fluid that will become urine eventually. So anything moves towards the right, it is reabsorbed, and if it moves towards the left, it is secreted. Principal cells have sodium-potassium pump and is located on the basolateral membrane. Potassium is pumped into the cell, creating high intracellular concentration of potassium, making a concentration gradient favoring potassium flow to the tubular fluid via potassium channels at the apical membrane. Sodium channels located at the apical membrane allow sodium reabsorption. Sodium is a positively charged ion. The more sodium are reabsorbed, i.e. leaves the luminal fluid, the more negative the luminal fluid becomes. And since the potassium is also a positive ion, it will be attracted to move to the negatively charged fluid and thus will be secreted. So, what is the role of aldosterone in all of that? Well, aldosterone simply increases the activity of the sodium-potassium ATPase pump, as well as increasing potassium permeability in the luminal membrane and also stimulating sodium reabsorption. The rate of delivery of sodium and water affects potassium secretion. Increased distal delivery of sodium stimulates distal sodium absorption, which will make the luminal potential more negative, thus increased potassium secretion as seen before. What about the flow rate? Well, it's a very simple answer. The more water you have with higher flow rate, the more diluted the potassium in the luminal fluid becomes, creating a favorable concentration gradient for potassium excretion. Well, enough for the basic science, and let's have some fun with the clinical aspect of hyperkalemia. What could possibly cause hyperkalemia? As you can see in the figure, and as we know already by now, that 98% of potassium is intracellular, and the normal kidney is able to get rid of extra potassium. So there are two basic mechanisms for hyperkalemia. Either the potassium gets out of the cell, or failure to excrete the potassium. How do the potassium get out of the cell? Well, anything that ruptures the cell and breaks the cell membrane will release the potassium in the extracellular fluid. That could be crush injury, rhabdomyolysis, seizures, and hemolysis. The potassium can also get out of the cell with an intact cell membrane. Simply anything that interferes with the sodium-potassium pump action will do that. The following could interfere with the functions of the sodium-potassium pump. Digoxin directly inhibits sodium-potassium pump, and as we know by now that insulin activates the sodium-potassium pump. So if we don't have insulin, the pump is not going to work. So insulin deficiency, as in the cases of diabetic ketoacidosis, is another cause. Beta blockers blocking the beta-2 receptors, meaning no longer indirect activation of the pump, and again hyperkalemia. Metabolic acidosis and hyperkalemia was explained previously in lots of details. Another mechanism to get the potassium out of the cell with intact cell membrane is by using a depolarizing agent such as succinylcholine. Cell depolarization makes the inner cell less electronegative and the outer membrane more negative, and since the potassium is positively charged, it will be attracted to the negative side, which is outside of the cell. Failure to excrete potassium could be due to one of these reasons. Number 1, renal failure. Number 2, decreasing aldosterone secretion or action. Number 3, decreasing effective plasma volume. Renal failure, there's nothing much to say about it. The kidney fails, cannot work anymore, cannot get rid of potassium. Decreasing aldosterone secretion or action will need to be explained a little bit in details. So let's have a look at the renin-angiotensin-aldosterone system. Renin is an enzyme secreted by the kidney that converts angiotensinogen, which is a protein secreted by the liver, to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. One of the actions of the angiotensin 2 is to stimulate the adrenal cortex to release aldosterone. Anything that inhibits this pathway will result in diminished aldosterone secretion or action. For example, the renin could be inhibited by drugs such as aliskiren and nonsteroidals. You can also inhibit the ACE by using ACE inhibitors, or block the angiotensin 2 receptors by ARBs, angiotensin receptor blockers. And finally, you can antagonize the aldosterone action on its receptors using spironolactone. Decreased effective plasma volume, as in cases of heart failure, will also cause hyperkalemia. And how's that? Simply, less flow rate to the tubular lumen means less secretion of potassium and thus hyperkalemia. Before we go on to the next section, we need to mention that pseudohyperkalemia is an artifact caused by prolonged tourniquet use or hemolysis of RBCs in tubes, or simply too many cells as in the cases of thrombocytosis. The patient would definitely be asymptomatic, so simply repeat the test. An important question that is not answered yet: why is hyperkalemia a serious issue? Have a look at this figure. This is the action potential curve under normal potassium level. This is typically the resting membrane potential, and this is the threshold point. What hyperkalemia do to the resting membrane potential is it brings it closer to the threshold point. In simple words, it makes cells easily excited and ready to fire. Well, not that kind of excitement. By excitement, we mean excitement of the cardiac tissue resulting in arrhythmia. The following changes happen in order to EKG: peak T wave, loss of P wave, widened QRS complex. So how do we treat hyperkalemia? There are three approaches. Number 1, antagonizing the membrane effect of hyperkalemia to save the heart using calcium gluconate intravenous. But we only use it when there are EKG changes. Number 2, drive extracellular potassium into the cells by using insulin. Number 3, remove the excess potassium from the body. This could be achieved by renal excretion using furosemide, GIT excretion using ion exchange resins such as kyaxylates. Zirconium cyclosilicate is a new promising ion exchange resin with less side effects and shorter duration of action, or we could use dialysis as in case of renal failure. That concludes the presentation. I hope you find it useful and informative. Thanks a lot.